as well. So welcome, and let's have a look at Jennifer. Let me give you a bit of background. Jennifer started off as a male and now has become a female. Yeah, I found him just browsing around, having a look around, and I haven't done anything to it other than we tweaked the names a bit and fiddle around. But in terms of its content and what's being presented, you can see it's exactly what you say. It is what is on the tin, as it were. Any observations from it? How did you find it? It'd be interesting, because if it's positive, I'll do some more kind of searching around.
It was great. Yeah, it was really good case study, and lots of I think there's lots of areas and directions to approach from, because obviously we're all different types of therapists.
Yeah.
I think there's a lot of directions that you can come in on.
Yeah, I like that, Sarah. I agree with you. I quite like the age bit, her maturity. You got a sense of her, didn't you? You get a sense of her as an individual, and how would you treat her as an individual, not just the shoulder stuff. And I found that really interesting. So yeah, no, I agree. Anybody else want to feedback from it? Positive, complicated, too much, too complicated, too easy?
As a complete beginner, I like the fact that it was to achieve a particular sporting activity. So that's what she wanted to get to, so that you've got to point to the treatment for the individual. I like that.
Yeah. Hi, Ismail. Good evening to you.
All right.
Nice to see you. Well, I can't see you, but I can read your name.
That's good.
You're going to let us see you, or are you kind of not?
No.
No. Well, sometimes you're elusive. I understand. Right. Okay. Let's. So we're just talking, Ismail. I just introduced the case study, and I just want to get a bit of feedback if it was an interesting one. Anybody had any particular observations about it? Anything else anybody wants to say or jump in? Mark, what did you think? Josie, did you ever think about it? What came to your head when you started to read it? What jumped out?
Just in terms of like how the case study is presented, I mean, I like it. It's got good detail, and I like I don't know whether you added the questions in afterwards, but
no, it came as you read it. Absolutely.
Okay. I think they'll make for really interesting discussion points as we go through the case study.
Yeah. Okay. So let's. Where's a good place to? Anybody want to kick us off? Where, if this person walked into your clinic, yeah, where would you go with this? Are we happy with the terminology? Your evaluation revealed painful arc motion from 70 to 120 degrees during the right shoulder elevation. I think that I take that as abduction. That's what I took that as. And a positive Hawkins-Kennedy's test. Those people who haven't done level 4, Hawkins test is a test for rotor cuff injury, particularly supraspinatus, and it's where you hold the arm and it's pushed into medial rotation against the resistance, and it tests the medial rotation. It's a level 4 test that you learn on the course. Any observations about any other bits that you might want to bring in? I don't know quite where to start, so I'm kind of just teasing out. Where would you start with this? We've got a certain amount of information. What do we think?
I've just got a question, Chris, if I may. It says in the case study that her pain is on swimming, so I'm assuming she's doing front crawl. So that action would be, rather than a adduction movement, it would be the flexion and extension movement. So that, would you test for that as well, or is that covered in the Hawkins-Kennedy test, do you think?
No, you would. What do other people? There's a danger here that I do all the talking, and I'm not going to do that.
I would test for that, Anne. I would test flexion, extension, because actually, a bit like when you're running, your hip doesn't just march forward and backward. It actually comes out to come round to land again. It's the same with your arm, isn't it? You would extend, but look where I'm going now. In order to come into flexion front, you would. So I would do what you've said and do those different planes of test. Test all the planes.
Yeah, I agree with that. You've got all the range of motion there. Plus, when it talks about the painful art test, that's doing abduction.
Also, I think check for acromion, subacromion, and just getting in there, putting the hand behind the back, lower back, and just like how you feel your way through the groove and see how that is, and the impingement there.
Say a bit more, Ismail. I can't visualize quite what you mean.
I think it's the thing that you normally do as your party trick when you press into people's armpits for subscapularis, but working more directly on acromion and subacromion and checking for impingements and movement and working along that thread of line and the groove and just seeing where that is the pain threshold, what's the rotation like, and then again adduction, abduction, and flexion and all those movements, and seeing where the acromion really, where the niggle really is, I think, and get into the detail, I think.
Yeah, I think first as well, you've got to look at the history that you're given. So she was a runner and a cyclist. However, she started the swimming, and it said that she went straight into long distance swimming. So to me, she's gone too far too quickly in that sense. So this is going to be an overuse, an overuse injury, because she wasn't strong enough to start at that level. She should have started, with and built up to the long distances. And she's upped her speed and her distance recently. It says, but going straight into long distance, she's going to get an overuse injury if she's trying to. It doesn't say how far exactly she was swimming, but
it would be interesting to know what her stroke rate was. I'm actually a swimming teacher.
Oh, there you go.
So her stroke rate, because you see a lot of people who come from that world into the swimming world, and they thrash through the water. They don't glide, so they're overusing their muscles, and it puts a lot of strain on especially that area anyway. So I think that would be interesting to get a bit more detail off her on that, as to what would be her stroke rate, how often is she going, what, if any, warm up and cool down is she doing afterwards, and is she stretching? Because it puts a massive pressure on the shoulder joints if you're not used to it, trying to go to that distance. So yeah, I teach adult swimming, and I see a lot of that thrashing about.
I kind of guess again that would be very much part of the rehab, wouldn't it? Alongside your treatment and where we get to in terms of where we start, all that usual kind of question. Part of the rehabilitation would be very much getting some potential tuition in swimming, and improving. It's about technique here, isn't it?
Yeah.
Rather than just bashing your way through the water. Yeah. Good point.
And like Sarah mentioned, I think there's a physical therapist I follow, Dr. Caleb Burgess. He says injuries happen after doing too much for too little. Injuries happen when you do too much too fast, after doing too little for too long.
Yeah, I think that's exactly what's happened here.
Yeah, I think you're right. Yeah, that's a story in my life. That is.
You'd definitely be in that first conversation with her. You'd be checking what her training load is like and seeing what she's doing with that, and maybe having a look at the other stresses in her life as well.
You have a sense of something else, don't you? You have a sense of reading it. You have a sense of I don't know, just got a sense of a busy person with a lot of, like us all, I guess. But yeah.
Posture-wise as well, she's got weak lower and mid traps. It said. That's quite significant. Posture wise, whether she's left or right-handed, I'm going to imagine that, you know, the rhomboids and those lower and mid traps are under some strain due to a rolled shoulder. That's not going to, if she's right-handed, I mean, we can make a decision, can't we? If she left or right-handed. If she's right-handed, it makes it easier for us.
Yeah, she's right-handed. I mean, we've known her for a while. So.
Oh, we know her for a while. Okay, so that's good. So she could already have, you know, the rhomboids and the lower and mid traps are lengthened from the scapula drifting laterally. So she's got weakened mid back muscles, and there could be some shoulder rolling going on already, which is going to make that acromion area. What's the word? Well, it's misplaced, so it could be rubbing on the supraspinatus, which travels under the acromion, doesn't it?
Yeah.
Yeah, I mean, I think that's a good point. I mean, that positive Hawkins-Kennedy test, that's testing for the supraspinatus tendon impingement. So that kind of makes sense. But yeah, I agree with the weak trapezius, you know, is able to stabilize the scapula.
And there's a lot of scapular movement in the strokes.
Yeah. So range of movement, we've thought about, you know, medial lateral rotation, flexion, extension, the normal stuff. That upper cross syndrome, I kind of guess, sits with that, doesn't it? That protraction, not just a humerus range of movement here, but we're looking at the place or the positioning of the scapula. Yeah, I think we're going to flag that up, aren't we? And those two.
And its rhythm as well, and whether it's actually doing what it's supposed to do in terms of moving as the arm comes out into abduction and forward.
Something around stability and stabilization, and the slow twitching muscles and things around that. I think just looking at the makeup of the muscle mass around the back, and what level the compensation, are there compensations?
Yeah. Sorry, I just got somebody's trying to join us.
The thing with a swim stroke is, which Anne pointed out, is that there is flexion, abduction. There is you're using, you know, so there's scapular depression just as you pull right back, and just before you lift the elbow out, you're pushing back and down. That the shoulder is really put through almost every movement apart from horizontal abduction or adduction, just about every movement that it can do. So we are looking at all the muscles, and if there's muscular imbalances, like we know that we've got a weakened mid trapezius and lower trap, that's going to tell us that upper trap is probably overpowering and too tight. We've got the subacromial impingement, so the abduction side of things is probably being done by trapezius, by the upper trap. And so that as Ishmael said, the stability of that shoulder is compromised completely, because some things are being too strong, some things are being too weak. So that doesn't bode well for a good scapular rhythm, which is what you need when you're doing overhead strokes.
It's where the range of motion becomes really important, because it's all of those shoulder muscles. You've got the rotator cuff muscles, you know, is the deltoid starting to do too much with that subacromial impingement? You know, she's having trouble, isn't she, putting dishes away? So that's bringing her arm up and washing her hair, almost coming behind. So then, you know, lats potentially involved with that.
Yeah. I suppose that what's interesting is that in that paragraph, right, so Jennifer was asymptomatic during the examination of her left shoulder. During a follow-up appointment from the physician the following week, Jennifer was diagnosed with subacranial impingement. So we kind of, we're making now the assessment is that this is what she's got. She's got some kind of impingement under the cranium, be that bursitis, be that, supraspinatus impingement, short arm, so long leg of the bicep. Are people happy with that bit of anatomy? Josie, I know you've just jumped in. You're at the early beginning stages of the course in your journey. Are you happy with these bits of anatomy? I've set up a few bits in the background that I can screen share quickly some of the anatomy details if that's helpful. Would that be helpful for? It's always good for us all, isn't it?
Yeah.
I felt like I just picked on you, Josie, and I'm sorry. I didn't.
No, I don't want to slow everyone else down because it does. I feel like this is a bit out of my depth, but I'm happy to look at stuff in my own time. If it's going to slow people down, then I'm really happy just listening and taking it all in. It's helpful just to hear the way people are talking, to be honest.
No, I don't think you need to feel that at all. I don't think there's no slowing down. I think this kind of stuff is our bread and butter. And to have a group of people just thinking together a bit about it. In the background, I've got a couple of little videos I was going to bring in, just ideas that I've got, which I work with, and material that feeds me in my classroom. So I thought I'd share that a bit later. So don't apologise. Let me bring in. I'll just do the anatomy bit first, so we're happy with what we're doing.
It's always good to have a little bit of an anatomy refresher.
Yeah, you can't. It just makes us feel warm and cozy inside, doesn't it? Of course it does. Right, so we're familiar with this chap, and if I do my thing, we're just hiding stuff. So this is the position we're looking at. Here we are, and if I put can you see that all right? Is that all nice and clear? Yeah. So if I put in the soft tissue stuff, then we can see the ligaments and the bursas are really important because they sit in here. So when we talk about impingement, we talk about the gap between the humerus, the green bit, and this green bit becoming too close together. Happy with that? So there's a raising of the humerus closer to the this space in here. Yeah, look, you chip. Anybody wants to chip in with any bits, and I say things you disagree with, or a better way of putting it, then just shout accordingly. Please do. So when we have a movement of abduction, let me see if I can do this. Highlight. So here's the supraspinatus muscle. And if I take off trapezius, which I'm going to fade it actually, I'll just fade trapezius. And we can see that supraspinatus fits over that scapula above the spine of the scapula here. And in that underneath the trapezius, comes across and joins onto the top of the humerus under these two bursas. And its movement is here. Is that sort of clear enough? Does that work all right? Happy with that? Just reminding ourselves, isn't it, what goes on? And it's this motion that when the muscle comes up, it gets caught in this space. In this space, here's the deltoid, and in this space underneath the cranium, these bursas either get inflamed, so bursitis, or there is a impingement here. There's bony, what's the word, spurs that grow underneath subacranial bursas. I can't think of the right word, so forgive me. That grow underneath here, and the distance between the humerus and this space here starts to lessen. There you go. Quick. Just always helpful, isn't it? Just to remind ourselves, get our head around the language of the muscles. So when we talk about rotator cuff impingement, or in this phrasement, subacrania, so underneath the acranium impingement, is exactly that. It's where the supraspinatus, as it comes up, it gets caught and squashed or irritated. The tendon for it gets aggravated, and you end up in this place where you get soreness and inflammation and, of course, pain. So that's what Jennifer's been diagnosed with by her whoever physician. And then, so now what? Hi, Pippa.
Hello, found you eventually.
Yeah, that's fine.
Sorry.
Yeah. Sorry. Now what? Silence prevails.
Well, I think getting the shoulder back into a more comfortable position, trying to get rid of that rolled shoulder by working through pecs is the first move. You have got inflammation there, you have to remember, so that might take a while to go down. So this isn't going to be a miracle treatment where it's always wonderful when you have one, but this won't be one, unfortunately, because the inflammation will need time to go down. But you can certainly reset a little bit the shoulder joint by relaxing off muscle tissue and using a little bit of, heel of hand and just forcing that shoulder joint backwards a little bit and try and reset the joint so that the catch.
So your first thought would be looking at we're making an assumption, which is probably a really good one, that this lady is protracted.
Yes.
Yeah. And
Yeah.
if she is, then our task is going to be getting that shoulder back, getting retraction, so that what's your think? Why would we do that? What difference is that going to make to this subacranial impingement?
Once the swelling goes down, once she's rested, because that's the other thing, is you're going to have to manage this individual's expectations, because your literature says she has a passion for swimming and the coach is really encouraging. So to then say to her, I think you should rest this for a bit because it's inflamed, or it appears to be inflamed and you've been diagnosed with it, that's going to be difficult to manage for her. But once she's rested it for a bit, I forgot the beginning of the question, my brain's just gone. The front doorbell just went then, and it's totally distracted.
I was just playing in my head, really, trying to think that the question for all of us is not
posture
where do we start? What do we start with? And Sarah set the stage by saying, look, actually, I would think about retraction. I would try and get this shoulder blade back where it belongs. And that would be my starting place, with starting to improve and reduce the kind of tightness in relation to this humerus being too high up in its joint, and closing the gap between the top of the humerus and the underneath of the acranium. Yeah, is that right, Sarah? Have I quoted you right?
Yeah, and I would work all the fibres of pec major, because some of them attach to the clavicle, and the clavicle comes in and meets the acromion as well. So if you've got a problem with the clavicle, well, you're addressing both of those.
Yeah.
It's not. I don't think you can test for whether it's the clavicle or the part of the scapula, but at least you're covering both. And I would also work into pec minor as well, because as with the swimming stroke, we said there's all sorts of shoulder functions going on, and one of them is depression. So when you're pulling back down and using your lats to pull your arm back, you're actually working pec minor with depression. So I would go deep into there and get to pec minor as it attaches to the Oh, it's gone right out my mind now. What's that little spot called?
Coracoid.
Coracoid process. Thank you. It's one of a few that attach there. I would be wanting to get the shoulder blade back and down, and I would have to work pec minor as well. So start light and get deeper and deeper into the chest.
Okay, I'll do a little bit of screen sharing on our friend, just for that, just reminding ourselves of the anatomy around here, which is always helpful. Here's the pec minor that you're talking about, pec major on the other side. So pec major absolutely, attaches to that clavicle, sternum underneath the breastplate, and then comes across and joins onto the humerus, and is all to do with the arm of the humerus. And then on the other side, we got that pec minor you were talking about, Sarah, and that real game planner of trying to reduce and get some movement of retraction. So I can just quickly, just so we can see what pec minor does, we can just see that movement as it pulls us forward on the arm. Let me just pull over that way so you can see it better. So its job is protraction. So when we're round shouldered and the scapula is sitting too far forward, and we're rounded in our positioning, then the two muscles that are related to that are both here, pec minor, and the other one under here is anterior serratus anterior. So you work on both of those to try and, as you say, Sarah, bring the scapula back. Yeah, I think that will be your first port of call. Just helpful just to bring in those little bits. Just fun to be able to see them. Just to add the. Right. Any thoughts, Mark? Where are you going?
Yeah, I mean, I like what Sarah said.
Agree. You're not allowed to just say, yeah, no, I'd go with that.
I like what Sarah said. Hold on a minute. Hold on. I'd also start looking at the rotator cuff muscles as well and look at which of those are tight. Obviously, she's got that, something going on with the supraspinatus, but I'd certainly want to look at all of those. If some of those are tight and it's kind of pulling all on that shoulder, then you might have a look at loosening some of those off as well.
Yeah. Look, I've got a there's a bit that I bring in, and I just want to. I don't know now's the right time. If it doesn't work, then tell me, and I'll change my ideas. But as a guy that I do, I've been on some of his stuff over the years, and I really like him. I've teamed up a couple of little videos from him talking about the when we get this protraction and retraction, there's a danger that we forget about the clavicle, and particularly the two joints where the clavicle joins onto the sternum, and where the clavicle obviously comes out and joins onto the AC joint, and that and what goes there. And I just thought, if it's helpful, I'll run the let me just open them up, and if they last, are you happy with that? I don't want to kind of, we've got time, and I think it's, well, I'll run one, and then you can say, thanks, Chris, that was a pile of rubbish. Next time you have a good idea, just keep it to yourself. So this one's called Don't Blame the Rotor. People come across Dortmund. Sarah, have you heard of this man?
Yeah, love him. He's brilliant.
He's an interesting chap. He's been to the UK over the years, not many times, but he's a mild nutcase, which I quite enjoy, which suits my philosophy. This is a 5-minute long thing. If you've seen it before, Sarah, shout. But let me run it and just see what you think.
This is Eric Dalton at the Freedom from Pain Institute, and today I want to talk about rotator cuff problems, particularly what we call impingement syndrome. My orthopedic surgeons tell me that about 80% of the people that come into your practice with a shoulder problem, suffering from supraspinatus tendinosis or impingement of the rotator cuff muscle, superior rotator cuff muscle. It grows out of this supraspinous fossa, has to dive under the acromion here and attach to the greater tubercle. And of course, when the arm is elevated, sometimes it gets pinched. So that is the problem. And typically as a manual massage therapist, we get in here and start immediately trying to friction this thing, stretch it, doing all sorts of stuff. And I'm gonna try to talk you out of doing that today. So to begin, we just need to remember that as these scapular elevators, the upper traps, levator scapula, etc., upper part of the serratus anterior, elevate this scapula and clavicle, the medial head should drop down. So as the clavicle comes up, this part of the clavicle comes up, this part should drop down. So we're going to be testing by putting our fingers on the top of the sternal heads of the medial clavicle here and having them either shoulder shrug and watching to see which side does not drop down, and elevation of the arm, abduction of the arm. As the arm comes up, everything should move up. The scapula should be moving up, clavicle should be moving up, this should be dropping down. The other motion is not quite as important for a rotator cuff, but it's important for to keep this thing mobile and to keep the mechanoreceptors from causing reciprocal muscle spasm, guarding in the chest wall, can tighten up the pecs, causing that sort of dragging down of the chest wall, can cause the latissimus dorsi to internally rotate, spasm and internally rotate the girdle, which puts it in an odd position there, right? And so as the client arms forward, this thing should drop back. So those are really the two motions. We're going to check shoulder shrugging, we're going to check for arm abduction, we're going to check for protraction. Those are the main three. Okay, we've got Keith on the table here, and we're going to look at the sternoclavicular joint. Remember the motions at the sternoclavicular joint that we are going to test. Basically, protraction, when the shoulder comes up, the medial heads of the clavicle should do what? Drop back. And when he goes into arm abduction at 90 degrees, the medial head of the clavicle, the sternal head of the clavicle should drop down. So one should drop back, the other should drop down. What about shoulder shrugging? So same thing with shoulder shrugging. If I put my hands on the sternal heads here, right at the top, I'm right on top without pushing on the subclavian or carotid arteries. I'm on both sides, and I'm going to ask him to shrug his shoulders. And you see if you can tell if one's not dropping down. And you can do a simple treatment just coming out to the side. As I bring the arm into abduction right at 90 degrees, it should drop down. This is one way to do it, but if it's really fixated, then this doesn't work. So I'm just going to bring it out using my body. Notice how I'm stepping with my weight. I'm not pushing his arm. Okay, so I'm stepping and I'm just kind of dragging with soft finger pads, dragging that sternal head of the clavicle down. I've got his arm pinned like this between my body so I can do this. Okay, well, I've got to bring him into this, right? Because I'm bringing him out and I want this clavicle to drop down, right? So first I'm going to have it drop down. To do that, I'm going to take femur eminence in my hand. I'm going to put it right on that medial clavicular head. And I'm going to get my body so that I'm just moving my body. I'm using my body. I'm not muscling him around. I'm not using a lot of my energy. Femur eminence goes right on that head, and then I bring him to his first restrictive barrier of abduction, and I'm going to ask him to push his arm down toward his leg. 2, 3, 4, 5, and I bring it into a little bit more abduction. It's this motion here. So now I've got him like this. So now I'm just bringing him into protraction. pulling the arm up like that. And I'm just going to brace now. Instead of being on the superior, I'm going to be on the anterior border. And I'm just going to come up like this. Right like that. Now pull down on me. 2, 3, 4, 5, and relax. And I just come up like that. This works good too. Okay, so that's sternoclavicular. Got to do those.
I like it. If you've got a spare half an hour, have a play with Eric. He's man is a box of frogs, but he brings some lovely skills, and I've learned a lot from him over the years. So I really recommend that you follow him. And he's a lot on YouTube. There's a lot around him, and yeah, he's a good man. But I quite like that thinking. Yeah, we get obsessed with this humerus and what's going on and abduction and medial lateral. Absolutely. Let's go down the chain a bit more and see what's happening with the only bony joint for the whole scapula, which is against the sternum. And I think that's the assessment. He made it nice and clear in that video, didn't he? Assessment and treatment. MET obviously used there just to sort of get that movement going. What do you think?
Was he saying abduction just to make it clear that he was saying abduction?
Yeah.
Okay.
Yeah. It's kind of, I don't know. It's an American thing to do.
A lot of Americans say it that way. I don't know why.
Oh, okay.
We've got to be mildly careful. It's being recorded, so I've got to be careful what I say about that.
But maybe, Josie, you're right in it, because when you hear adduction, abduction, they sound very, very similar, don't they? So they specify AB, or mind you, AD and AB sound very similar too, don't they?
Yeah.
It's good though. Good though. Helpful? Is it helpful, these things?
Yeah.
Guess I was thinking.
This might be quite like, again, because I'm quite new to everything, and maybe what you just showed wasn't necessarily what you're like a direct translation as to what you're suggesting, but like the movements that we just watched, if somebody had a shoulder injury, and it might just be because of my lack of experience, like I'd be so nervous to do any of those movements, especially if there was swelling.
Sure.
I think I know I've jumped in. Can you hear me, Chris?
Yeah, we can hear.
I know I was late coming in, but the whole point, I think, with the pain issue is you only ever work with the patient and check that they are, comfortable when you're doing these maneuvers. Maybe if the impingement is too sore and tender at that point, would you use, say, ice? Would you do any, reduction of swelling first? And that would be my sort of idea. Maybe that you need to sort of leave it alone, let it rest before you start working on these things. I think you always have to work within the pain threshold, and make sure that you're doing these maneuvers when the client is comfortable. Does that make sense?
Mm-hmm. I think it's useful for us to, we know, don't we, if something's hot and sweaty and inflamed, then we wouldn't be doing this work. It would have to be a place where careful treatment, like Sarah brought in, I would work carefully, and first couple of treatments might be quite superficial, and then gradually, depending on how that was received and what happened afterwards, would depend on how deep you went the next time. So I think it's, sure, there's an injury and it's inflamed, then we wouldn't go there. I think we have to make the assumption here that this is sore and tender, but actually workable one, with care and all the obvious common sense.
I think what you have to realise as well is that they are not weight bearing when you're working on them. So when you ask them to lift, they're weight bearing and all the muscles are firing, but when they're laid supine and you're just working on the muscles, they're chilled, they're relaxed, and that makes it easier for you to work because the pain isn't firing off due to muscle use, because the muscles aren't in use. So it would be easier.
Anyway, I hope that was helpful. Just adds to that thinking about the clavicle in terms of that being a factor and making sure that those joints are being assessed and moving freely. That, and if they're not, then that's going to be a contributing factor to the untying of the issues, isn't it? And where do we start? You know, where do we start? Do we start playing with retraction and trying to get that better and opening up the clavicle that I've just seen? And if that starts to get better, at what point, you know, where do we go from there? I was looking for the questions really, and just having a bit of a look at those.
I've lost the questions. Oh, here we are.
Well, I'm just, but you know, what anatomic tissue might be impinged and causing Jennifer's pain? Why would swimming have been a contributing factor? I think we covered that quite well, haven't we? You know, and you brought that in really clearly, and other people too. So that seems pretty. The impingement is fairly common, especially with why do you think that these structures are prone to injury? What happens to this relationship to bring the humerus nearer to the acranium? Why does that happen?
Constantly looking forwards. Because we have that natural, you know, leaning forwards quite a lot of the day, especially if people are working at desks, working at computers. Is that what you mean?
Yeah, mate. Yeah, I think it's. I don't know. I just asked the question: why is it that the humerus gets closer to the acranium over time? What causes that? Sitting at a desk and being round-shouldered would be a contributing factor.
Posture, lifestyle, lack of adequate exercise to balance it out.
You need to have more detail on.
Sure.
A bit more detail.
So if she's been a cyclist, in this particular case study, there's a lot of behaviour that's been in this position for hours and hours on end if she's been doing distance cycling. And that might have led to then a shortening of certain areas around the shoulder girdle, which they then may have, when she starts opening up as a swimmer, have caused this issue.
Yeah, I just want more detail. I agree. I completely agree there. I think it's brilliant. I agree with you entirely. That's great. Now what shortening? Your words were shortening of tissue. Brilliant. What shortening of what tissue?
Pec minor, specifically.
I'm not being funny. I just think.
No. But I mean, because Sarah's obviously.
We could just say rub the shoulder where it feels a bit tight, dig in a bit until she says ow, and then back off a bit, and then rub accordingly, and then that will probably do us some good. But I'm just thinking,
would be interesting to see how tight the pec minor was on either side and whether it was of equal tightness compared to the injury that she's presenting with and her lifestyle choice of being a cyclist and how that's manifested itself elsewhere also. Is that a bit better?
So, yeah, it's all right. I get dangerously for telling me to sod off. Mind my own business. Yeah, I think you know, this stuff, you know, is important to peel away. You know, that question is really, why does this happen over time? What is it that becomes? I suppose the word would be what is it that becomes out of balance?
Are we talking about the traps being weak, the trapezius being weak here, and
what aspects?
From the cycling, from the position of the cyclist being over? Are we talking about the traps pulling the weakening due to being in contraction constantly over time? And therefore weakening. So, you know, maybe they need to be looked at to balance the problem between the pecs and the working of the moving of the scapula around the back. I'm not sure I'm on the right.
I think it's all right, isn't it? It's all accurate in terms of, but I you know, people know me. I like to play around with the detail, and it would. We have to think about what muscles are pulling the humerus up and what muscles are pulling the cranium down, or what happens in that relationship between these two. And then the phrase that comes into our heads at these times is looking at our antagonists and synergists. And what are our antagonists and synergists around the structure? Does this happen because you're just old and get a bit wrinkly and you're round-shouldered because you sit down too much, or is this to do with an imbalance to certain muscle groups? And
maybe something going on with the traps and deltoid. If the traps are not strong enough, then maybe there's something going on with deltoid pulling up the humerus.
Didn't the case study say earlier that there was weakness in lower trapezius? Did that come in? Did I just read that?
Yeah, no, it does say that.
Middle and lower trap. So if there's mild weakness in lower and upper trap, the antagonist to that is upper trap. Yeah, because trapezius, half of it pulls down and half of it pulls up.
Yeah.
So by definition, if there's weakness one end, there's got to be over domination of the other end. Let me just bounce into that picture again. Just it's always helpful, isn't it? Just to remind ourselves of this stuff. So here's our trapezius, and our case study, we're hearing that the lower trapezius and middle trapezius, there's weakness. So that causing, I think your idea, Sarah, was that was causing protraction, lack of stability. Yeah, I think that was your kind of where you went. And therefore, if these muscles at the back here, if these muscles at the back here are weakened, excuse me, through here, then there's going to be an over domination of stuff at the front, pec minor, pec major. So there's going to be a pulling in the forward direction and a weakness to stop a stability this way. Yeah, that was our hypothesis, whatever the word is, and I think that's probably a good one. So if she's weak in the lower trapezius and lower fibers of the trap, then by definition it would make sense. We don't know, she's not in front of us, that the upper trap is going to be over dominant. And if the upper trap is dominant, then I would lay your custard on deltoid being dominant too.
Well, the pain. Oh, sorry. Go on. The pain. Her pain comes between when she does painful arc at the point where deltoid and supraspinatus should be abducting the arm, which is up to from about 70 or 60 up to 120, and that's where her pain is. So those muscles are not operating as they should, and they're over dominant, and there's probably some shoulder lift going on before the actual once you get up to 90 degrees, there's probably a bit of a shoulder hitch going on, which shows that the upper trap is dominant.
Absolutely, completely agree with you. So at some point, can you see that okay? Does that come across? So at some point when she comes up to somewhere in there, I haven't quite stopped it, but somewhere in there is a weakness through stability here, and that's giving her over a lot of pain through the supraspinatus. Is that your hypothesis, Sarah?
Yeah, I know, and you have to remember as well that the deltoid has fibres anteriorly and posteriorly, And if you've got a rolled shoulder, you're going to be tighter through and shorter through the anterior fibers of that deltoid. And as you can see where it's attached to, it attaches to the spine of the scapula and it attaches to the clavicle. So if it's only the front fibers that are strong and tight and short, they are going to draw the clavicle and the acromion together, which is going to cause an impingement.
Absolutely, spot on. And I think that's the nugget of our work here. Absolutely, upper trapezius and deltoid, and what exactly? I think that's a real. It makes it really, really clear. You'll get that. Can you see that picture? Can you see that, Josie? Is that? Can you see the mechanics of where we're at? I know you've been thrown in the deep end. You haven't got any armbands or anything. You're just bobbing up and down, holding onto a stick. But it's good to see, isn't it? And it's fun to look at. And nothing wrong with being thrown in the deep end. You just we won't let you sink. It's fine. So I like that, and I think that's the nugget of what happens here. So how does that relate to aging? Because there's something here that Jenny said. She's older. What is that a contributing? Why would sorry? And why do you think these structures are prone to injury as we get older? Is that just wear and tear and life and posture and just the things that you were talking about, rounded shoulder, just poor. As we get older, we get more knackered. Is that the general gist of the scenario here?
Definitely a factor.
Thanks, Sarah. Definitely a factor. We'll go with a factor. Are there antagonists with the positioning of the shoulders here? Are there antagonists that we might want to think about strengthening to stabilize the scapula or open up and get the humerus more in a better place? Eric Dalton kind of mentioned it when he was talking about his protraction issue.
Yeah, lats, and I'd be looking at lats, lower traps, rhomboids, pulling down, depression of the scapula, just to make sure that there's equal force through the front of the chest and the back.
Yeah.
And that just keeps the shoulder in its place.
And it's all about putting the scapula back where it belongs. And that's the work. Put the scapula where it belongs. And latimus dorsi connects to the arm. It's a strong medial rotator and also an adductor. Obviously brings the arms back down, but it's the complete opposite to the upper trap and supraspinatus. So getting that in balance and getting the lats stronger but longer is going to be really important. And the key balance here is length and strength. I think we could fix it. I think there is a light at the end of her tunnel. I think we've answered the next question. During the elevation, the physical therapist noted painful arc movement, typical on shoulder impingement. Why do patients with this condition category have no pain when elevation? I think that. What do you think? Now, don't all rush at once. Take it easy on this one. Why isn't it painful below 70 or above 120? I think didn't you say this, Sarah? I think you kind of, it was what you said, I think.
Yeah, so when you abduct the arm up to 70 degrees, that is only, it only takes supraspinatus to get to that level. And then the deltoid kicks in at 70 degrees. And if everything's working great, you should be able to get up to 120 degrees just using those two muscles. However, very often, because the upper trap is such a dominant muscle, and we make it dominant with the way that we live, which is what Philip has said earlier, I think, you know, and how we sit at a desk and how we're always rolled in and holding a mouse, etc. The upper trap takes over. So by the time you've got up to 120 degrees, it's the upper trap doing the work, and it's the dominant muscle, and it doesn't cause any impingement.
Yeah. Where are you, Mark? You any thoughts or any feedback, thoughts about this, or where are you?
Yeah, I mean, I thought the same thing, that's the sort of that's 60 to 120 degrees is where both the supraspinatus and the deltoid are kicking in and abducting the arm. So if there's an issue there, that's where you feel the pain, not below and not above that.
Have people seen this in your clinic? Have people had this kind of impingement in the clinic? Have you had it?
Yeah, I've got somebody who I saw just before second lockdown. I think it was somewhere between when I was allowed to work. She worked in textiles. She did a lot of curtain making, sewing, hanging heavy curtains, carrying heavy curtains up and down stairs. So yeah, she did come to me with an issue. You shouldn't come to me with that particular issue to start with. She came to me with a back problem, which I think had occurred because of the whole carrying the weight and the forward working on the machinery had caused a problem in her back, and she said, "Oh, and I can't lift my arm." So, you know, unfortunately, because of the injury she'd got, she wasn't able to lie down. So I wasn't working on the lower back. I said I'd be better off working on you know, the issues around her shoulders and allow the back to recover first. So so yeah, so I've yet to see. Obviously I went through the range of motion that she could do, and it was clearly that she couldn't take it beyond the when the supraspinatus comes into action with the deltoid. So yeah, I did some work with her when she was just literally sat up, and did you know, some basic massaging techniques to release some of the tension in the upper traps, and to try and build up some strength into the back of the lats, and so that we could actually get some movement. And then she would also, because of her sewing and constant doing this sort of movement, she you know, the whole of her arm was painful, so it was all down there as well. It was quite interesting, but I've only seen her once, so she was due to come back and couldn't.
Yeah, right. Okay, so yeah, one, two. Anybody else? What about you, Sarah? Have you seen rotator cuff stuff? This kind of impingement?
Yes, I've seen it a lot since people have been working at home. So using a mouse, using computers, and having a different setup. And sometimes it's the change in the setup. It's not necessarily that their setup is bad at home, but if you were sat at a computer before and your chair was a certain height and your desk a certain height, and then you got home and that all changed, that's going to actually set you in a different position, a different posture. So a lot of people were coming with that, and also pain down through levator and between the shoulder blades, which we've already discussed because of how they've been sitting. At work, we generally have a nice, well, most people have a nice ergonomic chair, and it helps them avoid pain, but as soon as you get home and you haven't got all that stuff around you. So I've seen it from that. And a change of mouse position, all that kind of thing has made a difference.
I used to have a quite a good referring relationship with a hairdresser, and it was a couple, husband and wife team, and both of them had in this, and it's quite common for hairdressers to, because they're holding the dryer in one arm in that kind of protracted position, and yeah, I've seen that many times, and it's a it's a very treatable condition that can be you can get great results, and avoid surgery. Anything else anybody wants to say about that, or should we carry on through the through the questions? I think probably the next statement we probably answered, really. Despite being very active adult, Jennifer's weakness in the middle and lower tract. Is this surprising to you? How do you think this weakness might be contributing to the impingement of the shoulder? I think we've nailed that, really, haven't we? We understand that the relationship, the imbalance of particularly upper tract and deltoid, is causing this moving together and irritation and misplacement. The key bit I want to get across, I think, in here. Let me just do back to this, if I may, just for a second, because I think there's a really interesting bit here that we need to forgive me. Let me just, I don't know, I've never done this.
This is Eric Dalton at the Freedom from Pain Institute, and today I want to talk about...
Go away. Don't want to talk to you anymore. You irritating. Go away. You do that. He butts in. Did you get that? Right. Let me just take this away. And I'll take this away too. Now, I don't know if I can get movement. I don't know if it's not going to let me do movement, is it? The bit I want to be just draw your attention to is the relationship in here. Oops. Can you see that? Okay. I'll put it in really tight because I want to make a clear kind of distinction that the I might play around with a pen. That's always dangerous for me, but I'll have a go. Right. So the relationship between this. Oh yeah, great. My artistic abilities, and the relationship between this is really important when we adduct the arm. Oops, sorry, that's supposed to be around the edge. Yes, I think I'll give up my artistic skills. When the humerus goes up, oops. Oh, that's not bad, is it? When the humerus goes up, the relationship here, this is shaped like a pear. It's not round, so it's not a ball and socket, tight ball and socket where it just slides over and it comes up. When the humerus goes in this position, the humerus here actually comes down. I'm going to colour that in. That looks really cool. Oh yeah, look at that. I'm quite good at it. So the humerus actually comes down as the head of the humerus comes down in its socket as the shaft of the humerus is adducted. And it's a really important concept to get your head round. So this is a moving joint. So if you have your deltoid over the top here and your trapezius and your all holding this fairly solid, then this isn't going to happen. The depression of this joint isn't going to happen. So therefore, the relationship between here, and the inside of here gets closer together, causing impingement. And I want to just make sure that you understand that the the ball joint isn't a ball joint. I mean, it classed as a ball joint, but actually when it comes down, it depresses, it comes down. So the relationship in this is really, really important. Oh yeah, I'm wasted. I should think I should take up this drawing game. Is that news to people? I talk about it in the classroom quite a bit. It's
no, I was thinking, I was going to mention the fact that it's quite what we'd call an unstable sort of structure, because it relies so much on, you know, these number of ligaments to keep it in place. So it makes it quite a fragile maneuvering part of the body as a joint, you know, whereas a lot of our other joints are much more stable in relation to other bones in our body, whereas this particular joint is the humerus is actually almost running free, isn't it, with the ligaments attaching it and hoping that they stay, as you say, in good condition. Once they start to weaken and lose strength or tear or whatever, it becomes a very unstable joint.
Sure.
I believe.
Yeah.
So
the moment you get in balance in this rotor cuff group, but also I think we talked a lot about deltoid, which is really crucial. You know, the moment that gets out of balance, the movement of the depression of the scapula of the humerus as it drops down and elevates is lost, and then you lose that. Then you get this long-term gradual closing of the gap between the subcranial surface and the bursas and the head of the humerus, and the tendon, obviously, for the long head of the bicep and supraspinatus. And that's the nugget that I think the go home bit is actually, I want to make sure that your MET is fantastic for this. It is such a powerful tool for level 4 guys, ladies, to use, because it's such a, you can engage and get the lats engaging and moving and being part of this still. And it's just sideline work, the elbow up at the side and getting people to bring their elbow down to their side and up, and it just works. And it really just changes and redefines the Golgi and spinal receptors, spindle receptors in the muscles to get this muscle out of its habit of closing down. So yeah, really, really good. Somebody want to chuck in any more about the actual treatment aspect of this?
The only other thing, going on from what Anne was saying earlier about, because she knows her swimmers and stuff, triceps also get very, very tight and stiff, don't they, Anne, on swimmers, and short. And because of where they attach, you've got one going onto the scapula, and one onto your humerus. So if either of those 2 out of 3 are tight and short, they're going to affect the movement of the scapula. And as Chris was saying, your scapula, as you bring your arm into the abduction, should actually do this with them.
Keep talking, Sarah. You're doing a good job.
Yeah. So your scapula should actually both the bottom, the inferior angle of the scapula should go out to the lateral sides as you bring your arm into abduction. And if that doesn't happen and it's stuck for whatever reason, it might be the subscapularis underneath that has adhered to the ribs and that area. It might be that the top of the trapezius won't allow it to drop. But basically that scapula should, as your arm comes up, there's a rhythm that should that says, I think it's something like for every 60 degrees that your arm abducts, your scapula should rotate 20 degrees. So it's a 2. I think I've got that right, but don't quote me on it. But basically, if the triceps attach to it and they're short and tight, you're not going to get that lovely rhythm going. and they're going to be part of the journey. They're going to be part of your treatment. I think I would definitely look at them.
Sure. I've identified long head of the tricep there. So 3 muscles, one ticks under here. So I'll just fade that one, and you can see, you know, the 3 heads under there. Okay. Yeah, nice one. I think what's always interesting, isn't it, is just that kind of journey of nibbling away. You know, start off with getting the shoulder back, start off with getting some freedom of movement, a bit more retraction and positioning of their scapula, and then start working on this trap deltoid, pec minor, pec major triceps. The next question here just talks about, other than the trapezius, what other muscle groups are will likely need to be strengthened? Brainstorm ideas for initial strengthening exercises for the weakened muscles, as well as how you would proceed with the pain lessons. I don't quite know proceed with her pain. I don't quite know what pain lessons mean. Oh, well, it's proceed as her pain lessons. Sorry, I should have said as. Yeah. I think we're beginning to pull that together, actually, aren't we? What would be classic strengthening exercises for lats, trapezius, lower trap?
Adduction exercises, but it would have to be, they'd have to be quite shallow because she can't lift her arm out too far. So you'd be looking at maybe weighting them and just doing a short range of motion.
Yeah.
It's the one where you put a roller on the wall. It's probably more on the serratus though, really, where they roll their arms up. So just to strengthen the lats, you're slowly moving the arms up and back down. Mind you, it should really be more this position, so it's probably the serratus actually. But quite often for strengthening the weakened rotary cuff muscles and around there, you could get them to just do very small movements where they're just turning a ball, you know, to say you're literally just drawing with a ball or going around in circles just to strengthen the rotator cuff muscle. Supraspinatus, would it be? I'm thinking, no, or is it the pec minor? That one. Yeah, twisting, I think. Sorry, it's getting late now.
I'm not sure, to be clear.
Stabilize. I was just talking about how you could use, well, it's not so much strengthening as helping to stabilize the movement. So you're just bringing your arm up and down or to the side, up and down, and just and twisting to build it up the strength there.
You can use flexion. You can use a rubber band with your arms out in front of you and then pulling the rubber band down, keeping your shoulders in a stable position. And then that just, with the back straight and the posture in the right position, that works the lats. And you could also do that in water. So when they went to their swimming lesson, they could also do that. So the rest of the body's supported, but they're still getting that motion through the water.
Yeah. I was going to, I mean, that leads nicely on to the last question, really, isn't it? Where is she in terms of, does she need to stop her training completely? Where do we go forward with that? What would our advice be? And, you know, just that, and, you know, should she stay out of the pool, or what would you recommend? Or, you know, where would we go with that? You know, that kind of, clearly the crawl isn't such a great move for her right now. So that might not be in the game plan right now, but
There are drills that she could do in the pool that wouldn't be as aggressive as doing a front crawl stroke, that would engage all the muscle groups that we've talked about in this session. And she could work on slow movement of rotation and looking at her body position in the water, and more stretching action to really get that. She'll probably have to work through some pain, as lots of people do anyway, to get the motion that she needs for that, almost like a circumduction in the water, just to get the joint, to keep the joint free and moving with the impingement that she's got. But I wouldn't say stay out of the pool, but it would be interesting to get a video of her swimming, so you would be able to see what's lapsing and what's not, what's compensating and what's not, so that you could maybe put that into your next treatment as part of your treatment plan.
This is where it gets really, it gets quite colourful now, doesn't it? Because this person's planning to do a triathlon in July. You're telling her to stay out of the pool, or what are we telling her? And she's saying, that's great, sod off. I've waited 3 years to do this. If I leave it any longer, I'll be in a flipping wheelchair. I'm going to crack on. And if it involves a bit of bruising and a bit of, suck it up and get on with it, I'm going to get on with it. It's really hard, isn't it? How we kind of educate people to think about actually short-term loss here could be long-term gain. But no. I've got a swimming session Saturday and I've got to perform. And there's no way I'm going to give up on that. That whole kind of conversation is a real toughie, I think. And this is why injuries don't go away, because people don't do the kind of groundwork that, as we said right at the beginning, the groundwork to gradually get to a point of being able to start doing some endurance stuff. People just jump in and think, great, literally jump in and great, and off they go. They want sort of full speed ahead from day one. And it's a lovely case study in that way. It's so typical. No, I don't know. We don't know enough about Jennifer, do we?
No, but like Anne said, there are definitely drills in the pool that she could do, even to keep her core and her legs strong, so that when she does come back and the shoulder can take, well, she'd have to start with she wouldn't be able to do the crawl, I wouldn't have thought, or backstroke, but once she can get her arms involved again and the strength is back there and the pain is gone, she won't have lost everything. She'll still have, so I would go for minimum damage, if you like, to her fitness, and tell her that she can do drills. So maybe she'd have to hold a float like this for in front of her and behind, or it doesn't matter if she's sort of backstroke or trying to kick forward, but either way she can hold a float, and also to strengthen the shoulder, I would start with low, like I said, just low level, either low circling. So that's always a good one to start off. So the shoulders coming forward in the front of the deltoid is being used, but then as you go backwards in a clockwise motion, you're also using the posterior part of the deltoid, because that's the bit that you've got to get strong in order to sack off the trapezius. You don't want this kicking in, so massage can let that go, but it's no good if this doesn't get strong again. So you've got to do some focusing on abduction and strength with abduction. So I think it was Anne that said to do with band, you can set up a band in the opposite direction that they've got to pull away, that kind of thing. But to start with, I would just use pressing up against the wall. It's an isometric movement that doesn't require, that just gets the muscles working together again, so that they know that they're supposed to be working together.
It's an interesting one, isn't it? My experience has been that in my career, I kind of had good relationships with personal trainers, and I found one or two that were very switched on in rehabilitation and really switched on with muscles engaging together. and you know, I spoke the same language as them, you know, rather than just huff and puff and sweat and lots of weight. It was all about conditioning and thinking carefully, and I like that model of referring off to other people who know far more than me, and that worked very well. It was a nice relationship to you know, share clients backwards and forwards over years, and because we've got to know what we do know, and you know, and to some extent you need to see 50 of these people in your gym all working with bands and weights and different ideas to come up with a really nice kind of rounded kind of rehab that strengthens all the things we're talking about. I don't know, well, I can bumble around and get some ideas, all the things we've been talking about, but people that do this all day and every day really works well.
But there was a lot of rehab in level 5. That was brilliant. That really helped me along. And I've done a strength and conditioning like the foundation level as well, just online. I haven't had to go in anywhere. It's just been something I've done over time. And that's really helped with giving your clients exercises to do that will help them along after you've treated them or between your treatments.
Yeah, absolutely. Nice one, Sarah. Yeah, absolutely. Level 5 is built for that, isn't it? It's all that kind of more neurological kind of patterning and rehab. Yeah, which is well, we've answered all the questions. Jennifer is now pretty sorted, I think.
Yeah, I've got to go, I'm afraid. So I'm going to say goodbye until next week. And thank you very much. It was really interesting. Nice to meet you all who I haven't met before. Nice to see you again, Mark and Hannah and Chris, obviously. And yeah, I'll see you next week.
Yeah, see you. Thanks, Sarah. Take care. Cheers.
Bye. I've got to find out how to get out of here now. Oh, there we are.
Any other any kind of thoughts, any other stuff that we need to think about for Jennifer, or what do you think?
I think as she recovers from the injury, you talk to her about getting back into the sport again and not trying to do too much too soon. You know, she can't then jump in and try and, you know, get back to where she was before she had the injury. She needs to kind of build up slowly. I think that's quite important.
And that judging the personal, but the person at that point, you know, for us, I think it's always a challenge for me about how do I talk to somebody about going, as you just said, Mark, how do you do that when you know they've got a deadline of I'm going to do this anyway, or that whole kind of debate. It's quite, I find it quite tough.
It is tough, and it's a very individual thing as well. I think, yeah, you kind of got to have that, build that relationship with the client. You've got to have their trust.
That's exactly the word, Mark, isn't it? That they got to trust that you understand what's going on for them, and therefore are going to listen to your guidance and support. Yeah, that's the key word. That's the key word. Now, what I'm going to do is I think unless anybody wants to bring in any more, I'm just going to stop recording, and then we can just F and blind and sweat. No. And then we can have a chat about other things. But is there anything else that anybody wants to bring in, particularly around the case study? I think it's gone well. I think it was quite good to get some clear kind of guidance on what was happening, you know, and then for us to think about our bits. I quite liked that. How did you find it? And Pip, what do you think?
I think it's excellent. I think you're right about the nibbling away at it and looking at, you know, what are the synergists, what are the agonists, and how do you then translate that into client speak that they'll understand what they need to either stop the pain and then improve. And, you know, like Mark said, doing too much too soon and diving back in. I find it really interesting, and it's nice to know the level of detail that you're looking for so that I can get my head around that. Absolutely. As well.
And my heart, poor old Josie, is kind of, she's bobbing up and down. I think she's all right. She's still with us. She hasn't just run off. But you know, this is a lovely example where if you don't know your muscle groups in detail and the relationship, how they work together, you're just going to end up giving this lady a rub around her shoulders, hoping that you kind of chase the pain and you end up kind of doing something where, in fact, you know, the understanding of what we need to do is very different. So nice. Let me stop recording now, and then we can say.